Good afternoon, everyone. My name is Parker Chambers. I'm a junior at Spelman College, majoring in economics and minoring in public health from Pasadena, California. And my research mentors were Dr. Sim Chowdhury, Dr. Nataki Osborne-Jugs, and Dr. Simone Charles. And today I'll be presenting on the impact of Medicaid expansion on healthcare utilization in young adults with evidence from the behavioral risk factor surveillance system. This is the overview of what I'll be talking about today. Before we jump in, I want to explain the reasoning as to why I chose this project. So this year I've been involved in a policy project on Medicaid expansion in Georgia, which sparked my interest in exploring its impacts nationwide, particularly on young adults. And as an aspiring healthcare leader, understanding Medicaid expansion's role specifically among young adults was something that I really wanted to explore further. Thus is the reason why I chose to pursue this research. And I'll be talking more about the Affordable Care Act, also known as ACA, throughout the presentation. So prior to the Affordable Care Act, the fragmented insurance system left many people uninsured. And this graph with data from 2013 shows how high rates of uninsurance, the fragmented insurance system, healthcare disparities, as well as rising healthcare costs impact the unmet healthcare needs among children and non-elderly adults. And there were numbers of people that have insurance through Medicaid, which Medicaid is for lower income people, though they have to be in a certain income bracket. And a lot of people just don't meet that, which eventually led to the ACA. And then also people had employer-sponsor insurance. However, there was a significant amount of people that were uninsured. Over 50% of children didn't have access to checkups or general health care compared to those who had insurance, such as Medicaid or employer-sponsored insurance. And then non-elderly adults as well didn't have access to health care either. And so as we discussed in the previous slide, though Medicaid did provide access to some, there were so many who did not have access, which is, again, how we got to the expansion of Medicaid. And we're now looking to see how this improved healthcare access. So I have a question. Who here knows someone who has Medicaid or that you have Medicaid yourself? Exactly. This is why it's such a relevant topic, and so I hope you'll understand further why. And this graph here is explaining this as well. Essentially, in years 2017, 2018, and 2019, adults 18 to 44 consistently report worse healthcare access compared to children 0 to 17, and older adults 45 to 64 and 65 plus, who mostly report better or same healthcare access. When comparing also insurance types, those with public insurance and no insurance report significantly worse access compared to those with private insurance. And uninsured individuals have the highest proportion reporting worse access, which is just highlighting that there are these persistent coverage gaps. And so overall, this is suggesting that disparities, while the ACA improved overall coverage, young adults and uninsured populations are still facing these barriers to care. And given that, I do want to explain more about what Medicaid expansion is. I've mentioned it a few times, and how Medicaid just became more accessible after the ACA. So before the expansion, only specific groups of people were eligible, so children, pregnant women, individuals with disabilities, and certain income limits by state and groups were eligible. And the ACA was signed in 2010, and it was just a major healthcare reform that expanded insurance coverage to lower income populations under 65 with incomes up to 138% of the federal poverty level, making more people eligible. And so this map is displaying that the blue states, 41 states, including DC, so far have expanded Medicaid, and then the green states, 10 states, have yet to expand Medicaid. They've opted out. And that's why there are still these consistent disparities in healthcare access. And in terms of access, there is a big drop in uninsured rates for both the 18 to 25 and 26 to 34 young adult age groups after the ACA. So staying on parents' plans until 26 played a key role for the younger group, and then Medicaid expansion and marketplaces helped the older young adults gain coverage. And ultimately, young adults face job instability and limited employer insurance. So these ACA provisions are filling this major gap. And this raises the question, what has been the impact of healthcare utilization and self-reported health among young adults? Or more formally, this is my research question, what has been the impact of Medicaid expansion post-Affordable Care Act on healthcare utilization and health status in young adults? And we will explore this into this empirical analysis. So next, coming into past work. Number one, let's talk about the economic burden of healthcare access. Low-income individuals will face more negative health outcomes and have worse health experiences. And number two, the correlation between health insurance and health outcomes. Individuals who have access to health insurance generally have a better economic standing than those without insurance. Number three, the impact of public health insurance on health outcomes. Having access to public health insurance improves both health outcomes as well as the management of disease. Number four, reduction in uninsured rates and improved access. Specifically, Medicaid expansion reduced uninsured levels among vulnerable populations, including low-income individuals. And then number five, mechanisms via which Medicaid expansion can impact healthcare utilization and health status. So reductions in patient debt and increased provider compensation are just two of the mechanisms by which Medicaid expansion improved healthcare outcomes and utilization. And I really want to highlight number six, which is talking about existing economic literature on the impact of Medicaid expansion post-ACA on health access and utilization. Medicaid expansion reduces out-of-pocket spending and has additional positive benefits that I've been describing in the past 5 findings. And most importantly, the impact that Medicaid expansion has on particularly underutilized states and areas. And I'm going to explain this more when discussing the utilized data that we had and showcasing the variability and adopting Medicaid expansion among different states and highlighting the persistent disparities in late adopters and never adopters. And these 6 themes are showing us that there's got to be an impact on Medicaid expansion on health outcomes, but we haven't examined from a specific economic perspective and the population-wide impact on general health and healthcare utilization among a large population base. So this brings me to my conceptual framework, and so there are a couple of frameworks that can be used to explain the underlying economic theory behind the research question. And so the first one is Grossman's health capital model, where here we're looking at the production possibility frontier curve, which shows how people balance their time and money between staying healthy and doing other things. And then the marginal efficiency of capital curve, which explains how over time the return on health investments decreases, meaning additional healthcare spending yields smaller benefits. And together, these models are conveying that early and consistent access to care prevents future negative healthcare outcomes, thus preventing the associating healthcare costs and utilizations that these outcomes would have. And this is an equation from Grossman's model on investment in health, where health is a function of the depreciation of health, time spent improving health, M denoting market inputs for health. And this is explaining how insurance enters into the health production function. And making this relevant to Medicaid expansion, early investment in healthcare, particularly in preventative care, reduces the need for secondary and tertiary care that would be necessary if a negative health outcome were to persist. So my second theoretical framework is that there's evidence that people are price sensitive to healthcare. And the most famous example of this is the Oregon Medicaid experiment in economics, where a random lottery gave low-income uninsured adults Medicaid coverage, and some were lottery winners who got it, and some were lottery losers who did not. And this experiment provided evidence that the demand for healthcare is indeed downward sloping. And this implies overall that in general, when people are provided with free healthcare, as in the case with Medicaid, they are more likely to utilize healthcare more. And as you can see in this table, lottery winners were likely to report better self-reported health than those who did not, as well as better mental health. So from this theory, this is the hypothesis that we derived. Medicaid expansion is expected to improve healthcare status by increasing utilization of preventative and necessary care through expanded coverage, lower healthcare prices, and increased investments in health. From our data, we used pooled cross-sectional data from the Behavioral Risk Factor Surveillance System, BRFSS, which is an ongoing annual survey from the CDC. Our analysis spans from 2015 to 2023, and we limited our sample specifically to young adults. We merged this data on Medicaid expansion from the Kaiser Family Foundation using state identifiers available in the Medicaid expansion, given the states that have expanded Medicaid. Don't say a pooled cross-section basically is an independent cross-sectional data that has been collected over time. Okay, so we have created the measures, which are the number of days, any days, and greater than 20 days of self-reported bad physical or mental health from these questions in the BRFSS, and then we also created controls on the respondents' individual characteristics as well as the socioeconomic characteristics. And so these are the dates of implementation. I know this is like a lot, but this is all the states that have implemented. This is all the states and whether or not they've implemented or not implemented Medicaid expansion. And so one problem is that a lot of the states have adopted this policy in 2014, and that's an example that's outlined in purple. And then the ones that we're adopting throughout different points in time are in orange, and then the states that have not adopted are in red. And this is our empirical model. So to kind of explain this further, health outcomes are any of the measures of self-reported health and healthcare utilization. Medicaid expansion is an indicator of whether they had it in that year or not. Z denotes individual characteristics. X denotes socioeconomic characteristics. And then we also added state and year fixed effects to the model, which are indicators that capture the impact of being in a particular state and year respectively. And year effects capture things like national time trends, so think about like inflation, things that can vary year to year, or a downturn in economy. And then state fixed effects are state level time varying unobservables, kind of like the unique effect of being in a particular state on the outcome variable. And then finally we have the error term that can have an impact on health outcomes that we cannot control for. So those variables will have a negligible effect. And then now I'll go into my results. So as you can see, we ran the first regressions on the number of days of self-reported bad physical and mental health. And so for this regression table, for example, just to interpret it, the column number 1 for bad physical mental health days, Medicaid expansions increased the number of bad physical health days by 0.038. But however, you can see we're getting a positive sign, which is not what our hypothesis predicted. So the effects are statistically insignificant and small in magnitude because we expected the sign to be negative, but we're seeing the sign to be positive. And we had similar findings for bad mental health days and for the other tables. So on the next regressions, again, we replaced the outcome with any days of self-reported bad physical and mental health. The results were similar, as well as greater than 20 days. Again, as you can see, it increases the likelihood of missed doctor visits, which is not what our hypothesis suggested. While the results are not expected, these are very preliminary results and there's a lot more to do. So the key takeaways from these preliminary findings are that there is little evidence of any impact, so the effects are statistically insignificant and small in magnitude. And the limitations are that there are several always adopters, which is problematic in the context of the empirical methodology that we adopted. And this is related to the fact that the question on self-reported health has not been consistently asked in the years before 2014, so it's hard to compare them, which is why we haven't been able to extend our analysis. And finally, that the BRFSS does not allow us to explore, due to the lack of measures, the effects of Medicaid expansion on eligibility and more specifically, how it's impacting Medicaid eligibility. Finally, I do want to discuss my next steps. So first, number 1, Medicaid is most likely to impact low-income and minority populations, as I've discussed throughout the presentation. So again, this is all very preliminary, but we want to look at women versus men, sex, race, income groups, also within young adults, various age groups. We also want to include other state-level time-varying controls, such as state-level data on food security and the percentage of population that's rural, all of which may be correlated with health outcomes and the implementation of Medicaid expansion. And then finally, Step 3, we want to implement more sophisticated econometric techniques that are currently being used in recent times to address limitations in the current empirical technique that we've adopted. So that concludes my presentation. These are my references. Thank you for listening, and I also want to thank my research mentors working with me throughout the year, and special shout out to Dr. Sin Chowdhury because we started later than everyone else, so we've been working overtime to really get this together. And additionally, I do want to thank the RAP team as well, and really thank you to my graduate mentor, Lindsay English, for all the help and support. So let me know any questions you have, I'm happy to answer them. Don't all shout at once. Yes.
Do you know if the CDC has brought the birth database back online and if there are any impacts on future data taking?
I know, that's a good question. I feel like all of that's up in the air right now. I downloaded, as soon as things were going up in the air, we downloaded the BRFSS data immediately, so I haven't gone back to check to see if it's not on the website right now, but I have been accessing the code book, so I don't think that it's offline. At least the code books aren't offline right now. Yes.
I was interested to see all the other analyses you're planning to explore. There's lots of things to investigate that are really interesting. And I was wondering about any kind of family level health indicators that may be included, because I'm wondering about things like caregiving. So if people have more access to healthcare, does that decrease the caregiving burden because people are getting help elsewhere? So I was just wondering if there are any kind of family level health indicators that could be explored with this question.
I think that's definitely a good point. There are so many different routes that you can take, so that's definitely something to consider for the future, because this is such like a detailed thing where you can look, there's so many different factors into Medicaid and healthcare access and utilization, because it's so specific to individuals and what they have going on in their lives. So that's definitely a good point that I'll definitely take note of, that maybe we can look into it. Thank you. I have not looked into that. Any other questions?